Okay, good afternoon. Welcome to this session on renal damage and to this exciting and innovative conference. Just to echo Steve's and Susie's words from earlier, this is a unique coming together of the clinical and scientific community, and great thanks to everyone involved in organising it. My name is Ganesh Suntharalingam. I'm the immediate past president of the ICS. Just before I pass you on to my co-chair, Tony Whitehouse, just a couple of housekeeping notes. So this will be two 25-minute talks, followed by a 40-minute panel discussion, including a third panelist who'll be joining us. The format for these, feel free to ask questions live as we go through. You'll be able to enter those into the chat box on the right-hand side, and they'll be passed through to the panel, and we'll ask them together at the end. And the emphasis will be on bringing all the questions and topics together for a kind of joint discussion for an extended panel. So that should be quite an exciting way of doing it. If you want to be anonymous, then preface your comment with anonymous. That'll come up as that. If you don't mind identifying yourselves, then please put your affiliation down as well, your institution, because then we can highlight that when we bring the questions up. We may not have time for all questions, but we'll get through as many as we can. And please note the session is being recorded and will be available on demand. We'd also like you to tweet during this. So the hashtag is COVID-19 conference. And we'll see if we can get a bit of interaction on Twitter as well. So without further ado, I'll pass you on to my colleague, Tony.
Thank you very much, Ganesh. Hello, everybody. My name's Tony Whitehouse, and I'd just like to echo Ganesh's welcome and thanks to this platform that we put out in the first time from the ICS and the Physiological Society. I'm one of the consultants in critical care in Birmingham, and it falls to me to introduce our first speaker. With great pleasure, I'd like to introduce Professor Claire Sharpe. She's Professor of Renal Medicine in King's College Hospital, and will tell us about the acute kidney injury and COVID-19, the clinical experience. Thank you, Claire.
Thank you. So as you've heard, my name's Claire Sharpe. I'm Professor of Renal Medicine at King's College London, and I'm a consultant nephrologist at King's College Hospital. So when I was preparing for this talk, it was interesting to look back on these early days of the pandemic and to realise quite how unprepared we were for what was about to happen in the kidney world. That was partly due to papers such as this that came out of Wuhan in mid-March, telling us that acute kidney injury was not a feature of the COVID-19 pandemic. And so at that time, it was really our dialysis patients and our transplant patients that we were worried about in terms of how it would impact them and our working during the pandemic. But perhaps we should have taken some messages from other papers that were coming out. This paper actually came out approximately the same time from the same province in Wuhan, telling us that AKI did indeed occur in patients with COVID-19. This was a larger cohort of 700 patients. And although it wasn't common, they only reported AKI in 5.1% of patients. They did highlight that those patients that developed AKI had a much greater increased risk of dying. And so although it wasn't being highlighted as a common feature, it was definitely, the messages were definitely there that it did occur, and if it did occur, it was a bad prognostic sign. So as you all know, we were very fortunate during the pandemic to get weekly reports from the Intensive Care National Audit and Research Centre telling us about outcomes of patients admitted to an intensive care unit on a weekly basis. And these were hugely informative at the time. And I have collated here some data from those weekly ICNARC reports from the week ending 20th of March through to the end of the week ending 15th of May. And this is really to help us think about what happened to our patients during the first wave of the pandemic. And what we began to realise quite quickly was that not only was AKI a bad prognostic feature, but it was also much more common than had been announced from the Chinese experience. And if you collated this data, towards the end of May, approximately 24% of ICU patients had received renal replacement therapy for acute kidney injury. But interestingly, that had varied hugely across the country. Some regions were only reporting 5%, whereas other regions were reporting as high as 75% of patients on intensive care needing renal replacement therapy. And it became very apparent that this was indeed a very poor prognostic feature for death. So although we'd had lots of time to prepare for the need for ventilators, we knew that intensive care beds were going to be of a premium. We knew that we would need to source ventilators for patients during the pandemic. We knew that before it had hit the UK. But we had not prepared in any way for the onslaught of renal replacement therapy needed on the intensive care unit. And this hit the media in mid-April, and it became a sort of crisis point as we approached the Easter weekend. And so NHS England had to prepare some guidelines for us in how to manage this demand for renal replacement therapy on intensive care units. And what was interesting from this report was not only did it talk about how to manage the resources for renal replacement therapy, but it also highlighted the importance of medical management. And although I don't work, I'm a nephrologist, I'm not an intensivist, we were never been in a situation before where we had to make difficult choices about patients based on the resources that were available. And this report from NHS England was really reminding us that we needed to put in as much medical management as we could, fluid management, thinking about drugs to bring down potassium, because we were really going to be limited in our resources for giving patients renal replacement therapy. They usually put together this table of ways in which we could provide renal replacement therapy to those patients who really required it. Those on the left-hand column, you'll all be familiar with the continuous renal replacement therapy modalities, which are commonly used in this country in intensive care: the continuous veno-venous hemofiltration and hemodiafiltration. And these were being heavily used on ICU, but these were the resources that were running out. We had got to a position where we didn't have enough machines, we didn't have enough fluid to run those machines, we didn't have enough filters to put in those machines. So all the alternatives are also highlighted on this table. In the middle, the ones that perhaps we're more familiar with using in our end-stage patients, the intermittent forms of hemodialysis. But these have been used in intensive care before, such as the SLED, which the slower, more gentle forms of intermittent hemodialysis. These require a certain amount of infrastructure to be put in place. You need pure water to deliver intermittent hemodialysis. And some units had the infrastructure ready for these, and others, such as ours, had to put this infrastructure in place rapidly over that mid-April period. But I'd like to particularly draw your attention to this last common, PD, peritoneal dialysis, which many of you will be familiar with, but some of you may not have come across before. It's a very low-tech form of renal replacement therapy. It's something that we've used at King's College Hospital to treat patients with end-stage renal failure for many years, but we've also used it to treat patients with acute kidney injury on and off, but we'd never used it in the intensive care setting before. It is something that's used in intensive care settings in developing countries where they are used to being resource poor, but in the UK, it's not something that's that you would routinely see in an intensive care. Just for those of you who are slightly less familiar with peritoneal dialysis, as I said, it's a much lower tech form of renal replacement therapy than CVVHD or intermittent hemodialysis. It involves the insertion of a catheter into the peritoneal cavity, and an osmotic solution is fused into the peritoneal cavity, which it sits there for a while, and waste products diffuse into this solution, and water is drawn out down an osmotic gradient. That fluid is then drained out and replaced with new dialysis fluid. The catheter can be inserted in two ways. It can either be inserted under general anaesthetic in an open procedure by a surgeon in an operating theatre, but it can also be done percutaneously, blindly at the bedside, which is the technique that we routinely use at King's. So I thought I would just illustrate this form of renal replacement therapy with the patient that we looked after. So this is a case study of Mr. MM. He's a 55-year-old Afro-Caribbean man, and he was admitted to King's through A&E very early on in the pandemic on the 11th of March with type 1 respiratory failure. He'd had a 1-week history of fever and cough, and he worked in a nightclub in central London, so he'd had lots of contacts with people who may have had a travel history, and he was a very had lots of risk factors at that time for acquiring COVID-19. However, when he was first tested on the 12th of March, he had a negative swab for SARS-CoV-2, which was not that unusual early on in the pandemic. However, that swab was repeated a week later, or 5 days later, because he remained at high index of suspicion, and that came back as positive on the 17th of March. He was initially managed with supplemental oxygen on the ward, but it continued to deteriorate, and you can see here his CT scan on the right, which shows typical features of COVID pneumonia. And he was transferred to intensive care unit and intubated on the 16th of March. This is what happened to his renal function. So when he was first admitted, he actually had a normal renal function. His baseline GFR was 81 mils per minute. But soon after admission, his renal function started to decline, particularly after he was intubated. He was treated medically for the first few days, but he was commenced on CVV-HDF around the 22nd of March. He remained stable on renal replacement therapy for a while, due mainly to his stability and our need to free up the resources of CVV-HDF. He was switched to peritoneal dialysis on the 1st of April. You'll see here that his switch meant that many of his parameters started to go up. You'll see his creatinine started to rise, and alongside that, his urea started to rise. And this, from a nephrologist point of view, is not surprising because we know that PD is not as efficient as CVV-HDF at removing these waste products. And there was a lot of discussion with our intensive care colleagues. There was a period of understanding these different forms of renal replacement therapy, and where we all felt comfortable understanding whether what we were doing was both safe and efficacious. So all, in the first wave of the pandemic, we treated 36 patients with acute peritoneal dialysis. All had their PD tubes inserted at the bedside by a member of the PD team. And these are some of their safety parameters at the 24 hours prior to the PD catheter being inserted and 24 hours after the catheter being inserted, when they'd received this form of renal replacement therapy for 24 hours. So we've looked at the PaO2-FiO2 ratio as a marker of how well easily they're being ventilated. Clearly these ratios are poor. These were patients with COVID pneumonia, and they were all ventilated and unwell on intensive care, but there was no deterioration in their PaO2-FiO2 ratio from the point of insertion of the catheter to receiving peritoneal dialysis for 24 hours. And this was important to reassure people, because one of the risks, one of the fears of peritoneal dialysis is if you fill the peritoneal cavity with fluid, could this splint the diaphragm? Could it impact on ventilation? And equally, were we managing to remove fluid adequately enough in order to keep the edema in the lungs down? So it was very reassuring that we certainly weren't worsening their ventilation parameters by switching them from CVV-HD to peritoneal dialysis. Equally, their SOFA score was identical both pre and post dialysis, indicating that their organ failure hadn't deteriorated. Interestingly, their percent of patients on vasopressors was slightly higher prior to dialysis than after starting on peritoneal dialysis, and the maximal doses of noradrenaline were similar. So we feel this is reassuring data that using peritoneal dialysis was safe. But it doesn't really tell us whether it was effective in replacing renal function. So also looking at those 36 patients, we have here the serum potassium over days after starting peritoneal dialysis, and the the daily base excess. And hopefully you'll see from both of these graphs that peritoneal dialysis was effective at controlling both potassium and acid-base balance. So it was really becoming comfortable with the fact that although creatinine and urea may be higher on peritoneal dialysis, the parameters that we are most concerned about, hyperkalemia and the base excess, we could control adequately without needing to use up the resources that we were running out of. So let's just step back a little bit and think about all AKI. If we go back to those Chinese papers, they were talking about AKI overall. And what we really wanted to know is not just about the intensive care setting for acute kidney injury, but what's happening in COVID patients overall. So there have been a number of papers that have come out recently, mainly from the US. And this is one from 13 hospitals in New York. It's on a large cohort of COVID positive patients, nearly 10,000 patients. And they reported that the incidence of death in patients that had acute kidney injury was much higher than those patients that didn't have acute kidney injury, in keeping with the reports that we'd had from China. And it was particularly bad in those patients who had to have renal replacement therapy for their acute kidney injury. What was quite concerning about this paper is that of those patients who had acute kidney injury and required renal replacement therapy on an intensive care unit who had survived to be discharged, 30% of them remained on dialysis. And so there have been quite a lot of questions that have come out of this. Has the COVID pandemic produced a sort of wave of patients who are going to be dialysis dependent as a result of their COVID? Another paper coming out of the US is this one, not quite as large, but still a large cohort, 5,000 patients with COVID-19. And they found that the overall rate of AKI was 32%, and 12% of them needed renal replacement therapy. But again, really worryingly from this data, 47% of those patients had AKI, had not recovered renal function completely by the time they discharged. The risk factors for AKI are the risk factors that we would recognise of severe COVID overall, so old age, Black ethnicity, being male, having hypertension, diabetes, being obese, and of course, noticeably, not surprisingly, having chronic kidney disease at the outset. Again, they noted that acute kidney injury was markedly associated with increased risk of death. But one of the interesting things they did highlight in their study was that the AKI rates decreased during the first 3 or 4 months of the pandemic. So they were at their peak in March, but over time they came down to a rate of about 27% in July. So we decided to look back at what our experience at KCH has been during the first wave between the 1st of March and the 13th of May to see how it compares with this American data. So between those periods, 1st of March and 13th of May, King's College Hospital remitted 1,248 patients who were COVID positive, of whom 487 developed AKI. So this was a rate of 39%, not that dissimilar to the rates that were being mentioned in the US. The risk factors, the characteristics of the patients can be seen here. And you can see that hypertension, diabetes, chronic kidney disease are all the same risk factors for developing AKI as in the US cohorts. When we do a multiple logistic regression and looking for predictors of AKI, we can bring out male ethnicity, male gender, Black ethnicity. The strongest, I suppose, not surprisingly, is having a baseline GFR below 60, and hypertension was also very strongly indicated. But what I'd like to highlight here is one of the parameters we included in our analysis was the use of diuretics as an inpatient. You remember that during the first wave, the treatment of ARDS, we were really being encouraged to dry these patients out in order to reduce their lung inflammation. And so many patients early on were prescribed diuretics. And I suppose in retrospect, it's not surprising that that was a risk factor for acute kidney injury, particularly on top of these patients who were very febrile and may not have been eating and drinking very well prior to admission. And when we look at the risk factors for death in our whole cohort, acute kidney injury is very strongly risk factor for death, as it has been shown in the American cohorts. But this is not just the AKI stage 3, not just those patients on intensive care needing renal replacement therapy, but also anyone that developed AKI stage 1 or 2. And this is the Kaplan-Meier curve showing the 60-day survival for patients who developed AKI as opposed to those that didn't. And you can see that the survival disadvantage is very much in those early days, and there does not seem to be a persistent survival disadvantage for those patients who had AKI, who have been survived to discharge and followed up. Interestingly, and perhaps reassuringly, of those who developed acute kidney injury in our cohort who were discharged alive, 85% recovered their renal function back to their baseline creatinine. And no one required ongoing renal replacement therapy. So unlike the American cohorts, we don't seem to have been generating a group of patients who have developed end-stage kidney disease as a function of their COVID infection. There will undoubtedly be some patients who had severe acute kidney injury, maybe those who had worse baseline CKD, who may well have a more rapid progression to end stage, but it is reassuring that it seems to be a better picture than the American cohorts. So let me take you back to Mr. MM. We switched him to PD. We saw this rise in urea and creatinine, but he did well enough and was extubated about 3 or 4 days after he was started on PD and was transferred back to the ward. He had his last dialysis day on around the 10th of April, and he was discharged home mid-April. He was last seen in clinic in October, and his follow-up GFR was 66. So although he had a GFR of 81 on admission, it has declined to 66. This would still be categorized as normal in the absence of proteinuria, but there's clearly been a significant drop in his renal function. One of the interesting things we found out looking at our data, prompted by that American data, was that we also found a decline in cases of AKI after a peak. So it peaked in sort of the end of March, early April, and as time went on, the incidence of acute kidney injury went down, however you work it out. So let's come back to where we are now and have a look at the ICNARC reports, which are a little bit more up to date. One of the really interesting things about these ICNARC reports is that they are reporting the second wave and the first wave separately. And if you look at the critical care outcome, if you look at those patients requiring renal support on ICU, since admitted from the 1st of September, as opposed to those admitted up to the 31st of August, you can see that there is a considerable drop in the number of patients needing renal replacement therapy in the second wave, as opposed to the first wave. And if you only look at those patients who are more severe, those who are intubated within the first 24 hours of going to intensive care, although their rate of renal replacement therapy is higher, it is still lower in the second wave than it was in the first wave. So this may be due to many things which we can discuss later. We know we're now using dexamethasone routinely in patients who are requiring oxygen for their pneumonia, but there may be all sorts of other things that mean that we're just better at managing these patients now than perhaps we were at the beginning. And this is the overall mortality, again separating out the first wave from the second wave, and you can see that this is having an impact on the mortality rate as well. So I'd just like to thank people. Primarily, I'd like to thank the patients, particularly those that we looked after in our first wave. And this is one of them, Maurice Marshall, who's given me permission to share this with you. This is a photograph taken of him in intensive care. He was the patient who I described earlier. And I'd also like to thank Elaine Bowes and Hugh Cairns for their fantastic work, putting in all those PD catheters and looking after those patients on intensive care. So with that, I'd like to finish. Thank you very much.
Thank you very much, Claire. Excellent talk. Just as a reminder to the audience, please keep thinking up questions and post them into the chat box. I've had a couple already, which we'll bring up at the end, so we'll get the speakers to answer them together. But it's my pleasure to introduce the next speaker, Professor Louis Forni, from the University of Surrey, working clinically at the Royal Surrey County Hospital. He's ideally placed for this conference because he's not only an intensivist and nephrologist, but he also began life as a physical chemist before he went to medical school and downgraded himself to doctor. So welcome, Louis, and thank you.
Okay, so this is following on from Claire's excellent presentation. I'll try not to make a complete hash of it. So lessons learned from the front line. This is the what I've been asked to talk about. This is to thank everybody for inviting me. These are my conflicts, none of which are relevant to what I'm going to talk about. Some of you may have seen this. Those of us who aren't old enough to have portfolios, or too old to have portfolios, should I say, aren't used to getting feedback from our lectures, but this has become a more regular occurrence lately. And this was one from the College of Anaesthetists that I received, which, you know, said some flattering things, but also said some things that weren't particularly flattering. So I'll try and do my best and not look bored while speaking. You can only see me in the little box anyway, so hopefully the camera isn't HD enough. So this was actually what I was supposed to talk about, renal physiology. But the problem is, as soon as you mention renal physiology, this is the response you get from some people. The more educated give you the Munch version, but they get very upset about renal physiology and slightly excited. So I didn't put it in the title. So why are we actually here today talking about this? Well, I'm here because I was asked by Hugh Montgomery to talk. And when I see Hugh, I'll have to remind him that this photo probably was taken when he was at high school and looks nothing like him, so it should be taken down from the internet. He obviously got some movie star doppelganger to stand in place. This is why we're here. Well, this is the Golden Crane Temple in Wuhan, which was a Chinese city that most of us had never heard of, despite its population in excess of 10 million. And this is the view from the hotel I stayed in Wuhan. So before you all gasp, don't worry, it was about 2.5, 3 years ago now, so it's well before the pandemic. And this was the only area of greenery I saw. This is Xiong Pen, who I've had the pleasure to work with, heads up one of the ITUs in Wuhan, so was right in the initial forefront. And this is something they gave you to eat in dinner, which is a very poor picture of a piece of snake, which I think I moved on rapidly to the vegetables after that. But there was nothing else too exotic on the plate. However, all joking aside, really, the seriousness of this pandemic really is quite phenomenal. When you look at the recent data, this is data from yesterday, from the World Health Organization, you can see the higher risk areas, the US, parts of Europe, some who don't report, unsurprising over here, and some with no new cases. The quality of this data, it's about as good as we've got. So, but some of the numbers are quite staggering. You can see that there have been over 250,000 deaths in the US now. And just yesterday, or day before yesterday, there were 3,000 deaths in the US. That's significantly more that died in 9/11, or in fact died in Pearl Harbor. So you can think the great tragedies in American history don't bear comparison to the pandemic. And sometimes it's easy to be a little blasé because it's been with us since January, really. But you know, the human toll is really quite significant. So is the mortality all related to the lungs, and is it all just secondary to ARDS? What about the kidneys? Claire's already very elegantly described the involvement of the kidney in C19 infection. So I thought we'd just explore that a bit further. Interestingly, I got this morning, and this is the Getting It Right First Time latest documentation. It's slightly ironic that we probably didn't get it right first time, but let's hope we get it right second or third time. which is an interesting read. I haven't read all of it, but these are the associations that have backed it. And you can see there seems to be a distinct lack of the renal association, I might add. And in fact, if you look through the rather lengthy document, this is the only bit really about renal support, that there were some issues regarding fluids in the first wave, and there should be some mutual aid with regard to renal services in subsequent waves. Ganesh and his pals did really well using home dialysis machines, which are also designed to be used acutely by the American manufacturers. And that Guy's and Tommy's made their own fluids, but as George Wender told me, that was a very small batch and couldn't have been scaled up for any further support. So it's interesting getting it right first time. Highlights problems with the renal function, but didn't talk much more about it. And as Claire said, we were all slightly thrown a curveball by this original report, which if it was true, we could have just all gone home now and, well, I was going to say gone for a drink, but those days are, somewhat postponed. There have been several reviews on the association of acute kidney injury in critically ill patients suffering from COVID-19. And this paper by Elie Zalou and his colleagues from Paris was the first to drag together some of the earlier studies, which showed that AKI incidence in hospitalized patients with COVID was not insignificant and varied dramatically from centers. And in ICU, again, there was some variability and went up to about 29, 30, even 50% in some of the early studies. So despite the initial data we were given from our Chinese colleagues, it wasn't true. And I won't dwell on the IGNARC data because Claire has covered that excellently. But this is just a snapshot from September. We can see that the early cohort rather than the later cohort, there was a bit of a difference in terms of split. And also renal support in terms of percentage went down quite dramatically. Remember, this isn't patients with acute kidney injury. This is patients on kidney replacement therapy. So as I highlight there. So what's the mechanism of infection? Is there actually a direct effect on the kidney? How do our patients get AKI, or is it all secondary to respiratory involvement? Well, if we just consider very briefly the mechanism of viral infection, of course, we now know, the man on the Clapham omnibus knows that the spike protein is needed for some of the vaccine, mRNA vaccine generation. And so things that never entered the general consciousness certainly have now. So the spike glycoprotein binds to ACE2 receptors, and then this fusion with the host cell requires transmembrane serine protease activity, which of course is a drug target for other conditions. This cleaves the spike protein and at the cleavage site, and this allows endocytosis into the host cell. There's a very good review on this that's just been published in here that I've outlined. So what happens in more severe infection? Well, in more severe infection, the adequacy of the host response is somewhat different. It's a classic blame the victim approach here. So there's failed viral detection. So virus inhibition of immune sensing occurs. You get suppression of interferons and interferon production, which of course is a major part of our antiviral strategy. Also, the virus can target host restriction factors, and there's also some inborn errors that make some individuals more susceptible to innate sensing. And in fact, some of the toll receptor, TLR7 and 3 that are coded on the X chromosome may explain why females are less susceptible to infection than males. They've got a better way of sensing viral infection. And then after this initial infection, we get this immune-driven pathology that we're somewhat familiar with now. There's complement activation leading to the coagulation problems I'll discuss in a bit more detail. myeloid cell changes and cytokine elevation. Cytokine is another thing that have become common parlance now. But neutrophils driving the pathology along with natural killer cells promoting tissue damage, and there's a lot of evidence that NK cells are ending up in the lungs. So failed viral detection then leads to this immune-driven pathology. Complement activation, NK cell dysfunction, the cytokine production, neutrophil activation, and all of this leads to the more severe spectrum. So a lot of patients, as we know, don't get to the failed viral detection stage, and certainly university students seem to be relatively spared, as we know. So what's the pathophysiology behind the formation of acute kidney injury or development of acute kidney injury? Is it all directly related to the development of ARDS? Well, we know that developing ARDS and acute lung injury can have a devastating effect on renal function. This was something that the ADCRI work group, which myself and Marlies were involved in, which was published earlier this year. And we discussed the mechanisms behind this lung-kidney interaction. And this is the effect on, of pneumonia, a pneumonia, be it bacterial or perhaps viral, leading to the patient with ARDS with being ventilated. Little did we know when we were writing this what was just around the corner. Hypoxemia and perhaps barotrauma leading to direct effects on the kidney as well as cytokine activation within the kidney. So we knew, or we know, that the effects of infection on the lung can have a direct effect on the kidneys, which may be due to the host response or may be due to our response in terms of the intensiveness. But is that the only cause? Well, there are, of course, other potential mechanisms summarized in this cartoon here. 4 main approaches, really. Vascular consequences, direct kidney invasion, cytokines, which you've heard about, and unspecified factors. So if we look at direct invasion, is there any evidence that the kidney is a direct recipient, if you like, of COVID-19 infection? Does the SARS virus infect the kidney? Well, there is some evidence that it does. I mean, there's some evidence in that viral RNA has been detected by recombinant techniques within kidney tissue from biopsies that have been done, and that's been fairly consistent. Viral proteins have also been detected by immunocytochemistry within the kidney. EM, demonstration of viral-like particles, well, that is an area of some debate, really. If any of you had to look at electron microscopy pictures, you know it's a bit like looking at a BBC weather map. You think you can read where the weather front's coming, but maybe not. So there are pictures that have been proposed to be virions within the cell, but others have said they're not, and there may be other protein structures that are not actually viral particles. So we'll park that. But certainly there's been recovery of live viruses from the urine, which explains the necessity for handling urine in special fumigation or fume cupboards if you're trying to do any research on the urine, which is a bit of a hindrance. There certainly seems to be some evidence that the proximal tubule, which is a major site of ACE2 expression in the kidney, may be associated with developing a virus in the urine, even though the presence of viral RNA in the urine has been somewhat variable. But certainly there is evidence, I would say now the evidence is that virus can directly affect the kidney. But what's the site of viral entry? You know, is it all ACE2? Well, interestingly, Joe Monmontra's group in the States published this fairly recently, that KIM1 and TIM1, so KIM1 is kidney injury molecule 1, could be a receptor for SARS virus in both the lung and the kidney. KIM1's an interesting molecule. It's been used as an indicator of early renal damage and acute kidney injury. It's certainly been shown to be elevated well before creatinine goes up in terms of nephrotoxins affecting the kidney. But it seems to be a receptor with a high affinity interaction for the virus. and the spike protein. And these are some pretty pictures which are stained for that. And interestingly, in animal models, you can block lung and kidney cells from uptaking the virus by anti-Kim antibodies, which is quite interesting, which could have important implications as we move on. So certainly the receptors might be slightly different. So is there direct invasion in the kidney? Almost certainly. Now, the coagulopathy, I'm not going to talk about at length because A, I'm not a hematologist, and B, I'm not sure everyone particularly understands its involvement in the kidney. But what we do know is that the SARS virus can trigger the complement pathway. For those of you of a certain age, that would include just two, the classical and the alternative. The younger members of the audience will also know about the lectin pathway. And of course, complement activation leads to the anaphylatoxin formation and the attack membrane complex, which can lead to vascular damage, VTE, and thoracic thrombotic microangiography, as well as DIC. And there's been lots of case reports of both microvascular, seen on renal biopsy, and macrovascular complications within the kidney. So certainly there have been cases of bilateral renal artery stenosis due to clot affecting the kidney. Right, and then this, right, the storm, the cytokines. So cytokine storm, which we all know so much about there. But I put to you, is it really cytokine storm, or is it more of a light drizzle? So what do you think? Well, cytokine storm syndrome is this kind of umbrella term. Macrophage activation syndromes, the hematologists knew them as. Those of us who looked after CAR T-cell therapy patients know that patients can get this impressive cytokine response, and there are these familial conditions that are rare. So cytokine storm syndrome kind of encompasses all of these. It's poorly defined, and it's somewhat difficult to describe. There are various criteria for HLH and H scoring, and some of you may be familiar with that. And you can see that classically in COVID-19, there are features that are very similar in both of these. So certainly there are some characteristics that are shared. But does it really help us, this term? I mean, it sounds pretty cool, but it can maybe categorize patients and therapeutic strategies, but I'd put it to you without a obvious definition or an easily categorized definition. It's difficult. Whether it can help research, I'm not entirely sure. So you won't be surprised to feel here that I fall into this group. It's a fairly inaccurate term. And really, these patients demonstrate a hyperinflammatory state that we see in other conditions, which I will discuss in brief. But certainly, if you're looking at the cytokines that are produced and the immunopathogenic damage that can occur, then it's quite interesting if you look at the different cytokines and what can happen and when it can happen. And this is a kind of granularity of data we just don't have yet. But certainly we know that certain cytokines are associated with certain clinical features. So, for example, raised IL-6 levels are particularly related to acute kidney injury in other conditions such as sepsis. The other problem is, of course, if we start looking at cytokine levels, well, when do we look at them and then when do we treat the patients? And that's a particularly important thing. So we're looking at our patients here on the critical care unit, whereas really over here is where we might be able to do slightly more good. And of course, the elevation of a single cytokine at any particular time doesn't make that a particularly useful therapeutic target. So we need more research in this area in these conditions. And probably my skepticism is backed up by this paper from Peter Pickers and his group in Holland, where they measured cytokine levels in critically ill patients with COVID and other conditions. Right, so they measured COVID-19 here with ARDS, sepsis with ARDS, sepsis without ARDS, out of hospital cardiac arrest, and trauma. These are TNF levels, not much difference for tumor necrosis factor. IL-6, again, very little difference. and IL-8, again, very little difference. So even though the levels of cytokines might be elevated, they're not super elevated above and beyond what we would see in other conditions. So there's little difference between that and sepsis. And then you've got the other causes, the kind of rag bag of everything else, like bad heart, bad lungs, tends to lead to bad kidneys. High PEEP levels, we know kidneys don't like. We're probably less aggressive with PEEP now as we've done the first session. Nephrotoxic drugs, well, they go hand in hand with being on ITU, so we have to be careful with those. Volume restriction, as Claire pointed out, I thought that addendum to her data on the use of diuretics was really very interesting. I remember writing initial guidelines on management of this condition and banging the diuretic drum. Now I just bang people for using the diuretics, really, because you know, really volume balance is critical for kidneys as well as lungs, and then hemodynamic instability, we know. So this might be expressed as the current renal view. Here's our virus jumping into the cell. What causes AKI? Third space fluid losses, cardiorenal type 1. What that basically means is bad circulation, no blood to the kidney. Excessive proteinuria. Now that can be associated with something called collapsing glomerular nephropathy. Not going to go into the details of that, but it's an FSGS variant, particularly seen in Black individuals in the US, but you know, the numbers are small. And then lower proteinuria is found in things that are commonly found in ITU. And this is what I'll put to you actually, that, you know, is sepsis-associated acute kidney injury really very different from COVID? This was an editorial I wrote with Mitchell Nadeem and John Callum, which got KI published. You know, are they both two sides of the same coin? And if we look at the etiology and the mechanism of sepsis versus bacterial sepsis versus COVID sepsis, you can see that, you know, both involve systemic inflammation. And as we know, steroids have been shown to show some benefit in COVID-19 in certain patients at certain times. Do we get damage associated with molecular patterns? Yes, we do, from both conditions. Do we get PAMPs? Well, certainly do get molecular pathogen-associated patterns from bacterial sepsis, and we certainly get viral RNA, which could be associated as a PAMP from COVID-19. Do we get thrombotic microangiopathy? As I've said, we do. Nephrotoxic drugs, well, they're common to both. Direct viral infection, well, clearly that isn't the case in bacterial sepsis. Cardiac dysfunction, yes, we do. And this macrophage activation syndrome, well, we see it in both. So looking at that, there's really not a great deal of difference. And if we look at guidance for management of COVID-associated acute kidney injury, this is the ADKI paper that got published in the Nature Reviews just a couple of months ago, where we did a consensus meeting online over 4 weekends and highlighted potential risk factors for COVID-19, which Claire also alluded to. But if you go through this list and you take out all the ones that could be associated with any other ITU patient or a patient with sepsis, you're left with not very much. And genetic risk factors, well, there are going to be some for sepsis as well, we know that. And so you're actually left with severity of COVID-19 infection and degree of viremia may well be risk factors for AKI, but we don't know. In terms of management, you know, there's not much we can offer at present, as we know. We try and prevent AKI. Yeah, we recommend regular use, a measurement of creatinine and other factors. Yes, hemodynamic optimization. Be careful with your fluids. Keep your glucose well controlled. Limit nephrotoxins, and don't use contrast. If you want further guidelines, here's the BMJ précis of our NICE guidance in terms of acute kidney injury. And then this is the rather elegant, I think, rapid guidelines suggesting what to do. So I would just finish last couple of minutes with, you know, is the picture changing? This is data from the Blue Journal that got pre-report came out last night. So you can't say I'm lagging behind the times, this and the Get It Right First Time group. So this is the latest paper from the ICNARC group. James Deutsch is one of the statisticians at ICNARC, and it's trends in intensive care for patients with COVID-19 in England, Wales and Northern Ireland. Those of you in the audience from Scotland, please don't think that's a biased thing. It's just that Scottish units are in their own case mix programme, not part of the ICNARC picture. And this is the trends with time. And so here we see receipt of invasive ventilation. This is pre-peak, this is during the peak, and this is post-peak. So you can see that our practice has changed, and I won't go into the whole CPAP debate there. Duration of invasive ventilation stayed about the same. But if we look at receipt of renal replacement therapy, you can see there's been a significant difference. And Claire alluded to that, but there's a significance down here to post-peak levels. And the duration, again, is somewhat different. But perhaps the good news, that's the final slide, is this. This is the adjusted 28-day in-hospital mortality with their 95 confidence intervals. See, this is overall, this is in London and non-London. I know London is ICNARC's based in London, but I think that's just because London and the South Counties did get the initial surge worse than the rest of our colleagues. And you can see that post-peak, there's certainly been improvement. And that's despite the fact that some of the patients presenting to us in terms of Apache 2 and SOFA scores are actually in a worse group. So with that, I'd like to thank you again for inviting me to speak. This is the view from my house in the summer, if you have a very powerful pair of binoculars. Okay, thanks very much.
Louis, thank you very much for a great talk, and I'd like to thank both of our speakers for their presentations, both which very, very interesting indeed. We've had some questions coming in, but what I thought I'd like to do first is turn to Marlies, if I may. Marlies is a consultant from Guy's and St Thomas's Trust. Could we just start off, Marlies, just by saying what was your experience of COVID so far, and did you feel that you heard anything different from our other speakers?
Thanks, Tony, for inviting me to this very interesting session. So our experience and my experience was very similar to what Claire and Louis described and presented. The thing which I could add is that in addition to all the challenges and the worries and the workload, I think there were also very positive things. And there are things which we can take forward into the next wave and even beyond, outside pandemic. So for instance, when we faced capacity problems, we and also colleagues in other hospitals learned to collaborate much, much better. So our working relationship at Guy's and Thomas with the renal unit has improved enormously because together we try to overcome this crisis. And the renal unit was fantastically helpful in taking patients off the unit, in providing intermittent hemodialysis, and helping us to get through this. As a result, we now have dialysis nurses who come to the ICU and have helped out in periods of shortage. And we have ICU nurses who are now learning how to provide intermittent hemodialysis. We've learned to appreciate the support from the renal technicians who were a major help during that particular Easter weekend in London, which Claire described. Without them, we wouldn't have been able to look and provide renal replacement therapy to all the patients at that time, because suddenly there was this big peak in London. And we've learned new ways of treating patients. So, I mean, I can't speak for Claire, but I don't believe that a unit in London would have used acute PD outside a pandemic. And we would have not used intermittent hemodialysis as we did. We would have not reviewed our renal replacement therapy initiation protocol as we had to. So I think we've all learned something. We've also learned from our pharmacists. So I think these are some cherries in this major challenge, but I think they will help us get moving forward and will hopefully also improve practice outside a pandemic.
Thank you. Yeah, and I suppose the first thing that springs to my mind is, what are your feelings about the differences between PD and our conventional renal replacement therapy? And what I mean by that is, obviously Claire presented data to suggest that actually the things that we'd normally look at in terms of creatinine actually might go up much higher than we normally would see in the intensive care, but actually the other stuff, the potassium and the hydrogen ions, were well controlled. Do we feel that altered outcomes at all?
Well, good question. I'm not sure whether I'm the right person, because I've not used acute PD in the acute setting, and we were sufficiently scared. So Claire and Kings and guys, we reached capacity roughly at the same time and discussed what to do, and opted for different ways. But we were sufficient, my colleagues were sufficiently concerned that PD may not work in our patient population. I think in terms of outcome, Claire is probably better placed here.
Thanks, Marlies. Thanks, Tony. Yes, if I might come in there, it's very difficult to be categorical about outcome, because there was patient selection, and this wasn't a randomized control trial, so I can't put my hand on my heart and say the outcomes were the same. We were selecting patients who were sick, but they weren't on an a worsening trajectory. We were choosing those patients who were either relatively stable, bad but relatively stable, to transfer onto PD, or those patients who were really struggling with their CVVHD. They were clotting their circuits. We couldn't get on top of their anticoagulation. So it was a different patient pool. We certainly didn't have more deaths in the PD group compared to those receiving. In fact, we had fewer deaths in the PD group if you were to compare them, and all of them that survived recovered renal function. So there was certainly no indicators of a worse prognosis, but it's very difficult to say because it wasn't a randomized controlled trial. Just to follow up on Marlies's point, the collaboration was key, and it was understandable. We were nervous doing it because we hadn't done it before, so it was understandable that the intensivists were equally nervous about it, but they let us do it. They let us contribute, and they gave us confidence. And there were periods, particularly towards the end of April, when more than half of the renal replacement therapy at KCH was in the intensive care was being delivered by peritoneal dialysis. So I think if there'd been any really strong indications that it was not working, we wouldn't have been allowed to continue. But as I say, unless we feel confident enough to go into a randomized controlled trial outside of a pandemic, or maybe in a pandemic, I'm not sure we can categorically answer that question, but it's certainly better than no renal replacement therapy.
Yeah. Thank you. I think we've had some questions from our audience. Ganesh, have you got those, or should I carry on?
Okay. So yes, I've got a few. I'll just picking up on some of the latter bit. The one question, anonymous, this one, was, are there any regional differences, do we think, in the, sorry, let me just, so I'm not misrepresenting the question. Are there reasons for regional differences in patients requiring renal replacement therapy? And if so, was it relating, do we think, to just the first wave and the timing, and some regions being harder hit than others, and therefore changing practice due to necessity, whereas others were places that are quieter were able to just carry on doing conventional CVVHDF?
Shall I answer that bit first, and then I'll go? So in our data, if you look at the risk factors, actually being of Black ethnicity as a risk factor for death fell out of the risk factors once you put in AKI. So I actually think a lot of the regional differences were around ethnic mix. There may well have been some regional differences around practice, but and I'm not aware of anyone that's systematically looked at the regional differences. I don't know what you think, Louis.
Well, I mean, if you look at the ICNARC data now, I mean, it's uncomfortable if you are one that's read the Black Report from the 1970s with the effect of socio-economic class on outcomes. you would have hoped in 50 years we would have moved on. But, you know, clearly there seems to be a relation to socioeconomic class and severity of disease. And so because of that, then, you know, if this group of our society get the disease more severely, then you would expect, therefore, they would get more acute kidney injury. I think that's a bit simplistic, but I think that probably explains any variation. I mean, in terms of treatment, I mean, I think that triggers for CVVHD or renal replacement therapy probably changed during our exposure to COVID. I also think we explored new ways of even treating with continuous therapies. I mean, I never thought I would have people on therapeutic heparin-based anticoagulation and citrate and direct thrombin inhibitors just to keep the bloody circuit going. I mean, you know, it was just explored new boundaries of wackiness. Yeah, and a lot of that was helped by, you know, my hematology colleagues coming to the unit and suggesting alternatives. And, you know, that was interesting because I went from the smugness of, well, we use citrate, we never have a problem, to like, oh God, what we're going to do. So I think there were probably changes in practice brought about by people being aware that starting early might not translate to a benefit from some of the studies and also might lead to further complications. So I would say probably socioeconomic class is as good a predictor as anything. We need Kathy Rowan to answer that. And probably our practice changed slightly throughout the period of time. But that's my own view.
Okay. One of the things that we perhaps haven't talked very much about is the effect of proning, both in terms of pressures on intra-abdominal pressure and then the effect on the kidneys, but also, of course, proning and peritoneal dialysis. Should we start with the first, just proning and generally the effect on kidneys?
I can say something about this. So I've looked into this, and there are no data that proning in a patient without any other intra-abdominal problem raises the pressure in the renal vein or any structure to the extent that kidney function goes down. So proning, it's in an otherwise a patient with no intra-abdominal problem should not contribute to acute kidney injury based on the existing data.
I'd agree with that.
And what about the experiences for peritoneal dialysis?
So we thought about this a lot. We anticipated that we might need to prone patients who are on PD. We took some advice from the South African intensivists. So Miniam McCulloch, who works in South Africa, and they use PD quite a lot in their intensive care unit. They have proned patients on PD, and they carefully monitor the intra-abdominal pressure, usually through a urinary catheter. And they feel that as long as the intra-abdominal pressure remains below 20 centimeters of water, that it's safe from both the sort of abdominal compartment syndrome and from splinting the diaphragm. So we were willing to try. We actually didn't have to do it. We only had one patient that was on PD and was then proned, and the intensivist chose to put them back on CVVHD, which was a perfectly reasonable decision while they were proned. But it's something that when we put the PD catheters in, we actually put them in a slightly different position, so that, because normally, if the normal position when you lie on your front, there would be a pressure point from the iliac bone where the catheter came out. So we put the catheter a bit higher so that that pressure point wouldn't exist. But we didn't actually get to do it, so I don't know.
Great, thank you very much, all. So we're getting some more specific questions around pathology by the look of it coming through. So the first one we've got here from Andre saying, this disease has looked a bit like catastrophic antiphospholipid syndrome. Any thoughts?
Well, yeah, because well done, Andre. Yeah, they're all part of the hyperferritonemic syndromes that, you know, rheumatologists would recognize as still disease, catastrophic antiphospholipid syndrome, macrophage activation syndrome, septic shock. You know, they can all be classed under that hyperferritonemic syndrome group. and have a probably applicable general pathway that affects all of them in a similar fashion. So I would say, yeah, call it what you will, but it's probably a catastrophic hyperinflammatory syndrome rather than anything. You can give it a label, but so the answer is yes. It looks a bit like that.
I mean, moving on from that, Louis, from what you were saying there are a lot of similarities between, the sort of sepsis and septic shock that we see from bacteria all the time in intensive care. And yet there seem to be a lot of differences as well. I just wondered whether you felt that the pathways were identical or whether actually what we're seeing is a multimodal renal hit.
Yeah, I mean, if you look at the risk factors for, if you just divorce the fact that COVID has to be special, right? If you just say, well, let's just look at this on day one, and you can say to yourself, well, actually, there are enormous similarities between the two. And, is there anything magic about COVID-19 and its effect on the kidneys? I don't know, I'm less convinced that it's magic. I mean, there are certain things that are different. I mean, the hypercoagulability is more pronounced than it is in a lot of patients with just bacterial sepsis, but severe sepsis. But, I suppose we'd like it to be different. And I guess that in the detail, there may be some slight differences. But in terms of a clinician management at the bedside, I think it's very similar. And what's encouraging is Claire's data that shows that, if you recover from it, you seem to recover, which certainly isn't the American experience, and also isn't quite as bad as patients with sepsis that recover from acute kidney injury. Significant number do go on to make a full recovery, but quite a percentage don't. And so that's why, in some ways, I was relieved to see that, and it mirrored what I've seen in our group, but our group isn't as big as that at King's or at Thomas's.
Yeah, that was something I wanted to pick up on, really, Claire, in as much as I noticed you were very specific in your words and said that the creatinines went back to normal. And obviously, we all know that creatinines is based on musculature. So it may be too early, but have you got any comment on that?
So yes, that's a really important point. And a lot of these patients were really deconditioned by the time they discharged. They'd lost a lot of muscle mass. And in fact, there have been reports in those patients that didn't develop acute kidney injury that they were being discharged with really low creatinines, abnormally low creatinines, which would be indicative of that loss of muscle mass. So I do think the jury's slightly out on whether we are going to have a sort of wave of chronic kidney disease coming through as a result of COVID. And I'm sure we know that all AKI is a risk factor for developing chronic kidney disease, and I'm sure we will begin to see these patients coming through. The FOS-COVID study is collecting follow-up data on many patients, and hopefully we'll get follow-up on some of these patients for long enough to really ascertain what the trajectory is. But I mean, in the short instances, it's reassuring they're not going home on dialysis, and we'll have to wait and see what happens in 2, 3, 4 years' time.
We've had a couple of questions around sort of severity of disease and viral load. Have you got any thoughts about that and whether that contributes perhaps more to direct kidney damage or whether it's simply all just immune system?
Well, there are certainly reports on viral load being associated with worse outcome, but it's very patchy, Tony. And the problem is that there are very few kinetic descriptions of patients with COVID. And so certainly where people have looked at viral load on ITU, well, that might be, as we know, 2, 3, in some cases even 4 weeks down the line. So you've got no idea what the viral load was on a week last Wednesday, which may have been the predictor. I mean, we just don't know. So, you know, I think you can propose modelling and you can propose things, and certainly looking at some of the extracorporeal techniques for removing cytokines and indeed viruses. You know, it may be that you have to apply these early on when the viral load is high, rather than when we see them. And so viral load at ITU presentation is, I would say, probably meaningless. And so, you know, until someone gives us some good kinetic data, we're not going to know. That may come from animal modelling. I don't know. I'm not a, you know, an animal modeller.
Ganesh, have we got any more questions from the side panel?
I think we haven't at the moment. I'll just acknowledge Jacqueline, who actually raised a question that you all in fact addressed, which is about the gender and ethnicity issue and whether there's a socioeconomic aspect to that. I mean, is there anything specific and physiological that we should think about? I know, Louis, you mentioned about proteinuria in black patients. Is that, do you think there's anything other than the kind of disease, COVID prevalence that's specific to kidneys that we should know about?
Well, the collapsing glomerulopathy has been described before, you know, and so it's just that there are, you know, different presentations of renal disease, but most of it is tubular dysfunction and ATN. I mean, but the problem with nephrologists is, you know, we like doing renal biopsies because that gives us some information, but patients on intensive care often don't get renal biopsies. And so we're kind of muddling around in the dark. And so, you know, we can gaze at the urine and get a bit of information, but, you know, really more biopsy studies would be useful. There's a bit coming out from America, but again, you know, they're convenient samples and quite often are done when, you know, people haven't recovered for a bit. So, you know, I don't think we'll know. There's a broad church of ways a kidney can be infected, as there is in sepsis. And probably nephrologists only get involved outside of dialysis when things don't seem to be going in the direction one would expect. I don't know what you think, Claire. Do you think that's reasonable?
Yes, yeah, and I think that's reasonable. I think it's it's really difficult to know what the pathophysiology is, and I'm not sure we're ever really going to get an answer to that. We're very bad at looking at proteinuria on admission, which might actually be a useful thing to do. And when we look back at our data, trying to see whether anyone had had a PCR sent on admission, the answer was no. And that's not surprising, because you know, we were worried about keeping them alive, not really worried about sending their PCRs. But you know, maybe moving forward, if in the sort of when things are a little bit calmer, we might be able to sort of get in there earlier and look at viral loads, look at PCRs and things on admission, and maybe able to get a better idea of that trajectory. But I'm not sure of anywhere that's doing that yet.
And certainly the American data showed that, you know, having an active urinary sediment was quite common in the ones that they reported. That's the problem, of course, in that, you know, it does make you wonder whether someone said, you know, my wee looks a bit like mud, so therefore they were selected to have a urine analysis done. I mean,
so that's an interesting point. I might ask you and Marlies, one of the things that we haven't talked about that was reported in a number of patients was a kind of rhabdomyolysis picture with high creatinine kinases, and we certainly had one or two patients that had CKs in the tens of thousands, and it wasn't universal, but it was certainly something that we were seeing every now and again. Did you have that experience? Do you think that's part of the pathophysiology of the AKI?
Well, I didn't. I mean, you know, I think we had one, maybe two, but interestingly, the ADKI group that myself and Marlies were part of our colleagues from the States, particularly the southern states, were adamant that it had to go in and it was a big deal. Do you remember that, Marlies? They were really quite, you know, and that was very different to what we'd experienced. So whether that means they use different drugs to us or something, I'm not altogether sure. But But I didn't think it was a big thing. Did you, Marlies?
No, wasn't. Not in our practice.
Yeah. So that's interesting. But the Americans, a few of them were adamant it was a big deal.
Yeah, I wonder whether there is a genetic predisposition. We certainly had one patient who got acute kidney injury with CKs of sort of 40 or 50,000, who wasn't intubated, didn't go to ICU, had renal replacement therapy on the ward and recovered. But you know, you see those patients anyway. Is that a COVID specific thing? It's difficult to say when the numbers are so small.
Exactly. Yeah.
Changing tack slightly. What about you know, what we're beginning to call de-resuscitation? You know, so more and more in ICU now, we're seeing a resuscitative phase, and perhaps, you know, our lack of willingness in the early stages to do proper resuscitation perhaps contributed to acute kidney injury. So we're perhaps being more willing now to actually give some fluid in the first part when we first start to ventilate these patients, or at least not keep them so dry. And not push the diuretics so hard. But what about the timing of the de-resuscitation and whether, for instance, to replace protein and replace albumin? Have you got any thoughts about those? I've stunned you in silence.
Well, the problem, whenever I answer this question, my inherent bias comes out. So I thought I might wait for Marlies or Claire. I'll play the sex card and get ladies first.
Over to you then, Marlies.
So Tony, it's a very good point, but so we clearly allow patients to be, as you said, a bit more, to receive more fluid in the beginning. And with regards to de-resuscitation, i.e. aiming for negative fluid balance or even giving diuretics. So my current practice is to treat them exactly as I treat any other patient who does not have COVID. The tricky part is obviously that we don't have reliable tools to determine euvolemia. So I use the same clinical signs and the same triggers in COVID patients as I would in non-COVID patients. Whether that's right or wrong, I don't know. But really assessing or determining euvolemia and assessing intravascular volume status is a huge need and is a challenge in this patient group, but obviously in all patients outside COVID.
That's right. If I'm doing the same as you, Marlies, I won't feel too bad. So, Louis, what's your biases then?
Well, despite the fact that I always bang on about there's no evidence for this or there's no evidence for that, I'm a great albumin fan, of which there isn't a great deal of evidence. So, but in terms of so if I take it back a bit, Tony, in terms of resuscitation in this group now, I'm far more liberal with fluid. I mean, not saline, because we tend to use balanced solutions, but I tend to use, I would use albumin, and that's a drug that's much loved by nephrologists, and buffered solutions to get patients to what I would class as their euvolemia. Now, whether that's due to using a non-invasive technique to measure fluid responsiveness, we've done that on the HDU, certainly. It would be nice to take that out of the ITU, but those days are somewhat in the future. And then in terms of de-resuscitation, I do exactly what Marlies says. When I think I'm on the recovery phase, then I may well even add in diuretics. But I'm less anxious about the lungs than I was 6 months ago. And I think that's probably all of us feel that. But whether that reflects in the fact that we also use more non-invasives than we did 6 months ago, don't know.
And what about sort of microangiopathies in the kidney? We're obviously worried that it contributes to shunt when we're ventilating. Do you think it contributes to disease of the kidney, acute kidney injury?
Yeah, I think almost certainly. I mean, as I did point out, I wasn't going to talk about that a great deal, because I'm not a hematologist. But certainly, that's been seen on biopsy. Whether it's to the same degree as we see in the lung, some of the two-phase CT scans are really quite impressive, aren't they? It may well do. What we really need to do is do some MRI imaging of the kidneys in people with acute kidney injury. So my mate Nick Selby in Derby is doing some of that, so we may be able to shed a bit more light on that. But certainly macrovascular disease. So, you know, I do know people that have been caught out with, you know, renal artery clots that, you know, have suddenly come to light when they've had a CT scan for something else.
Mhm.
So, yeah, it's an issue. How you treat it, of course, I mean, because, you know, we're anticoagulating the patients anyway. So I don't know if my colleagues have any thoughts on that.
Have you got any feelings about whether the renal recovery in these patients is different?
Well, I was going to come in and say, although TMAs undoubtedly did happen, I don't think you could have massive TMA in the kidneys and then get renal recovery 3 or 4 days later.
No.
So I don't think TMA is a major part of the acute kidney injury, even though it undoubtedly does exist. I think the recovery pattern, I mean, a lot of them in the first wave were on renal replacement therapy, I think much longer than the average ITU patient was, although that is now coming down. It's difficult to know if the recovery is significantly different, although, as Louise pointed out, if they remain proteinuric 3 months later or 6 months later, I think we will want to investigate them. And one of the really important things, I think, is that we follow these patients up, because a lot of them may well disappear back to primary care and we're not noticing that they actually have proteinuria ongoing, and therefore we don't know what their prognosis is for the future, and we won't have those opportunities to biopsy them and get some better insights into the pathophysiology. So we are hoping to follow up certainly the ones that were discharged from intensive care, and I would hope that other places are going to do the same.
Thank you.
I mean, the reality is we don't really know what recovery looks like because we can't use creatinine as our standard marker. That's the biggest problem, I think.
Yeah, I mean, we could, I mean, some places do use cystatin C, which might be, you know, more relevant in terms of whether you've recovered or not. I mean, you know, just a question of time.
Great discussion sparking off there. The moving topic to a slightly logistical discussion. So I think one of the things that certainly came out in your talk, Claire, and I think struck everybody here, at the beginning of the pandemic, there was lots of worry about ventilators and kind of making new ones out of vacuum cleaner parts and so on, all very useful. But actually, it was the renal side that really hit the crunch point, both in consumables and equipment. What do you think? How should we be planning for, you know, novel virus 2025 or 2030? Might be too speculative about the technology, might be an unfair question, but do you think, for example, critical care nurses, ICM trainees should be getting much more conversant on multiple modalities of renal replacement, so that we don't just have a single tool? Or how should we be thinking further ahead?
Marlies, you touched on this earlier.
Yeah, I do think we have to take some lessons and keep and not forget what we've learned. And certainly exchange skills and experience. We had, as I touched on, our dialysis, not 6 of our ICU nurses learned how to look after patients on intermittent hemodialysis. And we're trying to maintain the skill. It's a little bit tricky now, but we want to keep the skill because we noticed that there was a proportion of patients, and they were not the sick ones, but they were in the recovery phase after having had a period of CRRT, who were perfectly stable on intermittent hemodialysis. And we also detected some pumped beds and some water supply, which we weren't even aware of. So that allowed us to do 2 things. Firstly, we could save CRRT fluid for the people who needed CRRT and use intermittent hemodialysis. We could provide renal replacement therapy to several people during the course of a day. And it was a training opportunity. And I think we clearly want to keep the skills in case there's another disaster. It may not be a virus, it may be next time, it may be some other disaster, who knows what. So I think it is very important not to forget the lessons.
Thank you. And as you say, an important point there, it doesn't even have to be a multi-system disorder such as I think it was the E. coli outbreak in Germany caused a significant issue with the renal. So, okay, thank you. And I think sort of ending on a note of kind of collaboration, cross-skilling, which can only be a good thing. So I think we're up to time now. Thank you all for a very stimulating discussion. So particular thanks obviously to Claire, Marlies, Louis, and my co-chair Tony for today, for this last session's discussion. But also, as this is wrapping up the first day, just to thank you to all the speakers from the meeting so far. I think this is proving to be a very successful format in terms of people from different fields being able to bounce ideas off each other. And I think we have got a mixed audience as well. So thanks to everyone involved, including those attending and those listening later. As a quick reminder, so tomorrow's session starts at 2. So we look forward to welcoming back as many people as can make it. And lots to think about from today. So thanks to all of you.
Thank you.
Thank you.
Thanks.